Okay, so we're going to move forward into relapse therapies, and both of you have been very much involved in the assessment of regimens in the relapse setting. Recently, several have been presented. I'm just going to give those as examples of recent data. I think we were all interested to see the impact of the Isatuximab, which is the anti-CD38 molecule similar to Dara. And as one might expect, a significant impact of the 3-drug combination versus the 2-drug in the PFS, overall survival, and a little bit for the MRD. I would have hoped to see maybe a little bit more improvement there. Then follow-up data on the daratumumab, carfilzomib, dexamethasone. Again, interesting thing here, high level of benefit across the board, including Len refractory and Len exposed. Then I think something that is quite important, as we have presented before and you guys know really well, we were very pleased to see the results of the ARROW trial presented last year indicating the benefit with once-a-week carfilzomib. There was a concern if this would be fully well tolerated in frail patients and elderly patients, and so we have new data indicating that the once-a-week is in fact tolerable for the older patients, frail patients, and we have data from several sources, this one plus actually a couple of studies from the IFM indicating that. And then a final study where I think there's a lot of interest is, and I would say rather unexpected, that there is significant value in adding elotuzumab to PomDex, and this is the study indicating the degree of benefit with the 3-drug combination at 1 year and 2 years in the PFS, 79 versus 68, 68 versus 49. So really a significant ongoing benefit with this triplet, which is obviously well tolerated, which is quite important. And so I know maybe I need to start with you first on this, Philippe. You've been particularly interested in how do we sort out these combinations, decide which one to give first or sequence them?
That's very important, in fact. As soon as we are starting to treat one specific patient, we have to anticipate and to know what will be available at the time of the relapse. And we discussed a lot during the last 2 days during the meeting about the number of patients that are receiving lenalidomide frontline.
Yes.
Not only young patients, but also elderly patients. And they are receiving len until progression. So
right.
Many patients will progress on lenalidomide.
Yeah, so a major group.
Yeah, and then what to propose, what is the best option at the time of progression on lenalidomide. And we have now different possibilities. We have the combination of pomalidomide, bortezomib and dex, the PVD combination, yes, based on the Activism study, with very good results, in fact.
Yes.
And the PFS that is more than something like 18 months. But we do also have data from phase 2 with Carfildex Dara, Kd Dara.
Yep.
And Kd Dara could be a good option in
yes.
this situation. PomDex Dara or PomDex plus CD38 is probably a good option as well. So we have to think about how to sequence the treatment to find the best combination, in fact, of regimens to have a very long response and a very long survival.
Yes, yes. And as was discussed, what would be the cumulative cost as you sequence through
yeah.
all of those
yeah.
in terms of the PFS, the cumulative PFS benefit and the cumulative cost over those various regimens? And so, Joe, you've been involved, I know, particularly with the Isatuximab. How do you see that fitting in? I know that is, if I understand correctly, a registration pathway, that ISA PomDex. So
yeah, this will almost definitely be Isatuximab's indication, at least initially in the U.S.
Right.
Will be in combination with PomDex in people with more heavily relapsed myeloma. So sort of meeting the pomalidomide classic two prior lines.
Yes.
Whereas the pomalidomide bortezomib dex study you mentioned was a little bit earlier. That's
yeah.
why it's hard to compare the apples with the oranges
yes.
in terms
yes.
of the PFS. So you know, isatuximab is really a very similar molecule to daratumumab. It's given IV. It's a bit of a shorter infusion, although that'll be a bit of a moot point when Dara becomes subcutaneous. But I think that's where
will this become a sub-Q, by the way?
Not immediately, not immediately.
Okay.
But there is a development.
There is a
development
development
of Isatuximab sub-Q. Yeah, yeah.
But it won't be as obviously as quickly as daratumumab. And you know, with the, as we discussed earlier in this program, with daratumumab coming earlier, you know, when we think of sequencing, you classically think, well, at first relapse, I want to make sure I include daratumumab, but people may already be on it. So I think where ISAs get a fit is a little challenging because, to be honest, almost everybody will have had daratumumab, if not in their front line, then at their in front line at first relapse. We don't really know how effective isatuximab is once you fail daratumumab. I mean, I led a study in that realm.
There was a study.
I know. I started that study.
Yes. So can you give us some?
Yes, we need some results from that. Yes.
Early results.
When Dr. Richardson was asked about this at his presentation, he said, there was a study that has not yet been published. You know, he didn't give the details, and obviously we're still working through the data. But the short version is that it really doesn't seem to overcome the resistance that people have with Dara. I mean, that may be one of the most important questions we have in myeloma right now, which is, what do you do with the patient that is failing daratumumab? Do you ever use Dara again or not? I think what we may come to, in my simple suggestion in the short term, is you probably don't want to give them a Dara or Dara-like drug immediately. You probably have to give the disease some time to almost reaccumulate the CD38s and potentially use it later. So maybe we'll get into this alternating like situation.
There is another question mark, is that when we are using Dara during a long period of time, we are using Dara monthly.
Yes.
Then is it possible, if we are changing the schedule from monthly when the patient is progressing with a biochemical relapse, to move from the monthly to the weekly to try to salvage the rescue the patient, and that we don't have any data.
Right. I mean,
Dr. Richardson said that he has some examples in his clinics, but the data are not
examples
published.
Well,
yes, as well?
No, I've seen this also. Yes.
It's like the lenalidomide.
But we need proper data.
Yeah.
I think it's like lenalidomide maintenance. When people say, "Well, I'm on low dose lenalidomide maintenance,
you can
I
increase the
rescue
dose,
it by
add
increasing the dose?"
dexamethasone.
I'm not sure it's going to be the definitive answer.
No,
so I think,
no.
you know, in answer to your question, Brian, I think isatuximab will have a role. It'll be initially with pomalidomide, although it's going to be a partner with just about everybody else.
Sure.
But I think the majority of the time it's going to be well after daratumumab has been given.
And so one decision coming out of our working group summit here is that we do need to try to bring this information together and go forward with a publication to try to sort this out.
Yes.
And as was also discussed, sorting it out will be where a lot of the regimens are available, but also for many parts of the world where a lot of the drugs are not available. And so that's going to be important to sort that out for patients globally.
But some of the other studies that you mentioned, I think, are so important because we have these pool of drugs, and every time we add one drug, we're not adding one more option.
Right.
We're actually adding one more drug that can be combined with almost anything else.
5 new options.
That's right. That's why I think that the daratumumab carfilzomib combination is so important. Better data on the daratumumab and pomalidomide combination will be important for us. Because then you can look back and say, has my patient had this, that, or the other? What's the right menu? Well, and I hate to call it a cocktail, but hey, what's the right mix of things that is going to work well for this patient based on what they had before? So that's why I think some of these studies, although they may not seem like they're adding a ton, they're actually adding more options that can make the discussion with the patient a lot more facilitated.
Absolutely.